So now we had seen about the platelet number deficiency, which is leading to bleeding disorder. Now let's move on to the platelet function defects which are causing the bleeding disorder. So the first one will be Bernard-Soulier syndrome. So it is an autosomal recessive condition in which the defect is then there in the glycoprotein 1b9. So glycoprotein 1b9 present on the platelets is going to be defective. So this glycoprotein 1b9 was involved in the platelet addition, right? So this platelet addition, there is going to be a defect. And if you see the characteristic finding in a Bernard-Soulier syndrome, in a peripheral smear, if you see, you are going to get giant platelets. So quite big platelets are going to be there. So like the size of an RBC, you can get the platelet. So giant platelets are seen in Bernard-Soulier syndrome. So what will be the platelet count in this disease? So here the platelet count is normal. It's just the platelet function defect, right? So platelet counts are going to be normal. But since platelet function is defective, again, BT is going to be elevated. But what will happen to the PT and APTT? Clotting factors are normal. So PT, APTT is going to be normal. So whenever we have a platelet function defect, you'll have to check for that is if you get an isolated BT elevation with normal platelet count and APTT and PT which is being normal, you'll have to do some tests called as platelet aggregation studies. So under platelet aggregation studies, we use certain platelet aggregators, okay? And those aggregators, they'll then make a curve out of it. So based on the pattern of the curve, we can detect what is the deficient function in the platelet, okay? So what are the platelet aggregators they are used for? They use is ristocetin, then collagen, ADP, and then epinephrine. Okay, so these four are the ones which they use as platelet aggregators in the platelet aggregation studies. So firstly, we'll have a ristocetin. So what is ristocetin? So this ristocetin is a drug actually. It is going to help in the binding of glycoprotein 1b9 with the Von-Willebrand factor. Basically, it is going to help in the platelet addition. So ristocetin is going to just enhance this platelet addition. So while this ADP, collagen and epinephrine, these are actually going to help in the platelet aggregation. So they are going to help in the binding of fibrinogen with the glycoprotein 2b3a of the platelets. So ristocetin aggregation test, addition test is going to help in detecting the platelet addition defect, while aggregation with the ADP, collagen and epinephrine is going to detect the defect in the platelet aggregation defect. Okay. So now if you do the ristocetin addition test, what will happen? It is going to be abnormal, right? Because here there is glycoprotein 1b9 defect in the Bernard-Soulier syndrome. So 1b9 along with the Von-Willebrand factor only is going to cause the addition. So when 1b9 itself is not there, how can the ristocetin help in this binding? So this ristocetin addition test is going to be abnormal and there is going to be a flat curve. There is going to be a flat curve on platelet aggregation studies with ristocetin. While platelet aggregation with ADP, collagen and epinephrine is going to be normal because glycoprotein 2b3a is normal. So aggregation can take place while addition cannot take place. So this curve is going to be normal. So the second platelet function disorder will be a Glanzmann Thrombasthenia. So this again is an autosomal recessive condition. Here the platelet function is defective because there is going to be defect in the glycoprotein 2b3a. So glycoprotein 2b3a is defective. So what will be defective here? Platelet aggregation. So platelet aggregation cannot happen properly. So when platelet aggregation cannot happen, this clinical features, you'll have a characteristic history they'll give for Glanzmann's thrombasthenia, and that is there is going to be umbilical cord stump bleeding at birth. So in the stump of the umbilical cord at birth, they are going to have continuous bleeding. The bleeding is not going to stop. That is the classical history they given for a Glanzmann thrombasthenia. So here again, being a platelet function disorder, the platelet counts are going to be normal. Platelet function disease, so BT will be elevated. PT and APTT is going to be normal because no clotting factor deficiency is there. So these three are going to be the same as Bernard-Soulier. But if you do the platelet aggregation study, the ristocetin addition test will be normal because addition is not a problem here, while aggregation with ADP, collagen or epinephrine is going to be abnormal. So the curve is going to be flat in this. Okay, so this is how you detect the various platelet function disorders. Then we'll see about the third platelet function disorder, which is Von-Willebrand disease. So as the name suggests, there is something related with the Von-Willebrand factor. So the function of the Von-Willebrand factor as such is, so I already mentioned Von-Willebrand factor is going to be produced from the endothelium Weibel pellet bodies, and then Along with that, platelets and megakaryocytes also produce this von Willebrand factor. So von Willebrand factor has two major functions. Firstly, we all know it is going to help in the addition. So with glycoprotein 1b9, von Willebrand factor is going to bind and cause platelet addition. So that is the first function. Secondly, there is another function of this von Willebrand factor, that is, it is going to act as a carrier protein for factor 8. Okay, clotting factor 8. So it is going to be as a protective carrier protein. So without this von Willebrand factor, what will happen to the factor 8 is they will be damaged easily. So factor 8, I already told, it is a labile factor. Remember, it is quite prone for damage. So without factor 8, this factor, without von Willebrand factor, factor 8 is going to be lost. It is going to be broken down. So these two are the major functions of von Willebrand factor. So it is a carrier protein for factor 8. Normal T-half of the factor 8 alone is going to be just 2.4 hours. But when it binds with factor 8, its T-half half-life is going to increase to 12 hours. Okay. So platelet addition I have already mentioned. So glycoprotein 1b9 interaction with von Willebrand factor is there. So what will happen if there is a deficiency of this von Willebrand factor? Obviously, platelet addition cannot take place and factor 8 will be diminished because the carrier protein is not there, it is going to be damaged. So platelet count is going to be normal in this, as there is no platelet number defect. It is a platelet function defect here, right? And then the BT is going to be elevated because this glycoprotein 1b9 interaction is not going to happen, right? So platelet count will be normal, but the BT will be elevated. So in Bernard-Soulier, this was not there, while in von Willebrand factor, this is not there. Okay, so both of us, it's a platelet addition defect only, and factor 8 levels are going to go down. Okay, then we have various types of von Willebrand diseases. So basically, they classify it into 3 types. The inheritance of these diseases are also quite different. So usually it is an autosomal dominant disorder. While reading genetics also, we read it under the autosomal dominant, right? So here, this type 1, here it is going to be a quantitative defect. So quantitative in the sense, the amount of von Willebrand factor is going to be decreased. It is just a deficiency of von Willebrand factor, and this is the most common type of von Willebrand disease, and it is inherited autosomal dominant. Okay. Then we have type 3 von Willebrand disease. This is going to be autosomal recessive. Okay, this is going to be autosomal recessive. Here again, it is a quantitative defect only. But here the von Willebrand factor is going to be so much decreased. It is literally absent. Okay, so much decreased. So whenever von Willebrand factor is quite decreased, it is going to lead to the decrease in the factor 8 as well, right? T-half of the factor 8 is going to diminish. So decrease in levels of von Willebrand factor and factor 8 is going to be there. So very severe decrease is there. So this is the most severe von Willebrand disease. So most common is type 1, while most severe is the type 3. Okay, while coming to type 2, it is going to have both autosomal dominant and autosomal recessive patterns. So under type 2, we are going to have 4 subdivisions. It is basically a qualitative defect. So something in the function of this von Willebrand factor is going to be there. So you don't have to go into the details of it. So under this, we have 2A, 2B, 2M and 2N subtypes. So all of this is qualitative defect. Out of this 2A is going to be the most common, and it is autosomal dominant. So in 2A, it is actually the von Willebrand factor multimers are not going to be formed properly. So von Willebrand factors usually tend to form multimers. So the multimer formation and assembly is not going to be proper in 2A, and that is the most common out of this type 2. Okay, most common von Willebrand factor disease will be the type 1, most severe is type 3. In type 2, the most common one will be the type 2A. Okay, so clinical features, how will it be? So there will be a platelet function defect here, right? So platelet function defect, what is the normal presentation? You'll have petechiae, then purpurae, and also mucosal bleeds. So mucosal bleeds like epistaxis, menorrhagia is going to be there. Along with that, there is going to be decrease in factor 8, right? So factor 8 was diminished. It was a cofactor for, carrier for this factor 8 is going to be von Willebrand factor. So when factor 8 is not going to be there, it is going to result in a coagulation factor kind of a defect as well. So these patients are going to have excess bleeding from the wounds. So with a trivial injury also, they are going to have excess bleeding. So what are the findings in von Willebrand disease? We have already seen. So platelet counts is going to be normal here, BT is going to be elevated, and then PT is going to be normal because extrinsic pathway is not affected. So factor 8 was involved in the intrinsic pathway, right? So factor 8 intrinsic pathway is affected, so APTT will be elevated. And if you see the ristocetin addition test, what will it the result? It is going to be abnormal because it cannot bind without von Willebrand factor. Right? So this is the abnormal thing. So if you see this profile, it is literally kind of similar with Bernard-Soulier except for this. So platelet count normal, BT is elevated, PT is normal, while ristocetin is abnormal, the same as that of a Bernard-Soulier syndrome only. But in Bernard-Soulier, APTT will not be elevated. APTT is elevated in von Willebrand disease because factor 8 levels are going down here. So how do you treat this von Willebrand disease? So for mild forms of disease, you can use desmopressin. It is a drug. So desmopressin, it actually releases the von Willebrand factor from platelets and endothelium. So for releasing the stores of von Willebrand factor, we can use desmopressin. Then if it is a severe kind of a deficiency, then you'll have to use a cryoprecipitate. So cryoprecipitate is a blood product. So under blood products, we have RBCs, WBCs, platelets, FFPs and cryoprecipitate. So cryoprecipitate is the one you have in which you have factor 8, von Willebrand factor and factor fibrinogen. So only these three things are going to be there in cryoprecipitate. So when there is an afibrinogenemia or a von Willebrand disease or in a hemophilia, so hemophilia is factor 8 deficiency. Okay. So in these three conditions, you can give a cryoprecipitate to replenish the factors. Okay. And other than that, in a severe disease, you will have to give a recombinant von Willebrand factor only. So a drug kind of thing. It is a recombinant von Willebrand factor. So now we had seen about the various platelet function and the platelet number deficiencies.